if I would be interested in presenting to you guys. But he also asked what kind of topics I might be interested in presenting, and he gave me like a whole bunch of really cool topics to think about. And the one that kind of stood out to me was peripheral joint manipulation for a lot of reasons. It's really interesting. It's maybe not an area of the body that we think about manipulation as much, but it's also a nice place to, if you haven't done a lot of manipulation, it's a really nice place to kind of get our feet wet with manipulation. So if we're talking about manipulation, what is manipulation? What is it?
Grade 5 mobilization.
Grade 5 mobilization. So we're talking about grade 5, we're talking about where in the resistance or where in the movement chart. At the end. Yeah, near or close to the end. Good, good. So grade 5 mobilization at the end. What else? What else do you think about when you think about manipulation?
High speed.
High speed, good. So we talked about velocity. Good, good. What else about manipulation?
Low amplitude.
Good, excellent. So there we have all of our names that we might call it. Good. So you might see high velocity, low amplitude thrust, so HVLAT in the literature. You might see manipulation. You might just see thrust. Typically, it's described as at or near the barrier, but there are some high velocity, low amplitude thrusts performed in mid-range as well in some circumstances. So it doesn't necessarily have to be at the end of the range of motion for that particular structure that we're focusing on. Good. So since you guys that was the first years who got the stimulating lecture on mechanisms of manual therapy.
They've had the stimulating.
Oh, so they know. Oh, fabulous.
Regrettably,
so,
they're ensconced in like pediatrics and wound care.
Oh,
and
forget all that for the next. Forget all that. You know, you got to get through the board exam, but then okay. So I didn't say that. So if we're thinking about manual therapy and manipulation, what are some reasons that we would do manipulation? Why manipulation?
It's a lot of bang for your buck in a short amount of time.
That's really true. Excellent. You're maybe in a busy setting. You want a specific result, and you're going to get a lot of bang for the amount of buck that you put in. A lot of juice for your squeeze on this. It's a quick, fast technique. You're in and out. Good. Why else might we choose manipulation?
Patient preference.
Yeah, absolutely. Good. Yeah. Patient may come in with an expectation that they
do listen.
they did listen. Oh, it's good. Good. What else? What are some things that manipulation you might hear out in the world and might have to do some education of people? What about manipulation? What are myths about manipulation? What are things that don't happen with manipulation?
Resetting the joint.
Thank goodness. Right. So we're not realigning the joint. Good. Good. What other kinds of things have you guys heard?
It's a novel stimulus.
It's a what?
Novel stimulus.
It's a novel stimulus. Well, that's quite vague. Excellent. Yeah, good. I like it. I like it. Good. Good. Make the patients feel good about what you're doing. I love it. Good. What else?
I mean, some people are afraid of them, and
Yeah.
some people are sometimes should be more afraid of them. Like my grandmother was like, "Yeah, pop my back." I was like,
So it's,
Be
yeah, right? So we want to be able to appropriately screen our patients, right, prior to performing this technique on them. So it's not for everybody, despite that maybe some professions out there do manipulation on everyone that they treat. It isn't for everybody. What are some contraindications? What presentation might you decide, hey, this is not the right person for this technique?
Osteoporosis.
Definitely. Good. Osteoporosis. What else?
Super painful, super irritable.
Possibly. Yeah, definitely. If you're not able to appropriately position them, in particular, into that position to perform it safely. There's some good debate on highly irritable and whether mobilization versus manipulation might be more effective. But if you can't get them in the position, you can't do it correctly. Absolutely. What else? Just osteoporosis and lack of positioning? Why else wouldn't you want to perform a high velocity, low amplitude, quick thrust on someone?
Maybe someone has like a cervical instability.
Good. So an actual structural instability. Good. Good, good, good. Versus hypermobility. Yeah, you guys have had those discussions. Good. You guys are way ahead. You're like so far ahead of me when I came out of PT school.
They would, and I wasn't even allowed to do stem manipulation, so you have to wait until next year to take the advancement.
Yeah. Cool. What else? Why else wouldn't you want to do manipulation on someone? Patient preference. Good. Excellent. Right? Patient says no. What other kinds of, not necessarily structural, but maybe health reasons may we not want to manipulate? Besides osteoporosis. Along those lines? Yeah, good. So anything that may be creating some type of weakness in the bone, some type of structural issue in the bone, whether that's like in some kind of autoimmune disease, prolonged disease process, osteoporosis, some type of tumor metastasis possibility, something like that. Good. Okay. And then another big thing about manipulation, if you have a patient in front of you who's appropriate for this technique, you've evaluated them on day one. Prior to performing your manipulation, what would you say to the patient? It's a difficult question to ask. It was a bad question.
Ask for permission.
Good. So talking about consent, right? So we're probably putting the patient in a pre-manipulative position, which is taking them to that place where we're going to put them in during the manipulation, checking in with them, making sure they're good, asking any questions. We certainly think about that maybe more in the spine, but in the periphery, it's just as important to make sure the technique is appropriate for the patient. Cool. All right, good. So for tonight, we're going to talk about 4 specific peripheral joint techniques. So we've got an elbow, a wrist, proximal ankle, and distal ankle and foot. All right, good. Questions? Okay, cool. So make sure we ask as we go. What I would really like, if I don't forget, is to make sure we talk about indications for each technique. We talk about how to follow up your technique with an HEP and maybe some therapeutic exercise. And we'll try to do that for each of those techniques as well. So if I forget, make sure you remind me, because that's important as well. Okay, so I've got handouts, so you guys will have something to hang on to. I know everybody likes to have just a little something to hold on to. Good. There's plenty of extras if you guys want to give them to whomever is not here tonight. All of the techniques, under each of them is a link to a YouTube video for each of the techniques. So I have a YouTube channel with all these techniques. It's a little old. I may not be as confident of those videos as I used to be. It's so funny how things change. They're like 4 years old, and I'm probably a very different practitioner now than I was 4 years ago. But I think they hold up okay.
What's the name of your channel?
My name, Christina Myers.
Christina Myers.
Mm-hmm. Yep. I think you'll find in general that you'll see some different variations between clinicians with manual therapy. There's a lot of variations for a lot of different reasons. You're choosing a technique that will give you what you're looking for. Yeah, that's all I'm going to say about that. Okay, so we're going to start with our proximal radial head manipulation. So I think that's on page 1, first technique. All right, so thinking about proximal radial head manipulation, what are some indications, do you think, for this technique? When might we start thinking about using this type of technique? Let's all find, while we're talking, let's find our proximal radial head. All right, yes, good, lateral elbow pain, excellent. So the radial head can be a little tricky sometimes, right? It's right there by the lateral epicondyle on the humerus. So feeling that lateral posterior elbow, so anatomically speaking, where we're going to be is actually a little bit posterior than lateral. If you're not sure where it is, do some supination pronation, and you'll feel the radial head rolling under your finger. So you'll know where that is on almost any patient if you're setting up for this technique and you're not quite sure. Good. So definitely lateral elbow pain. So what kinds of diagnoses might that be?
Tennis elbow.
Tennis elbow. Beautiful. Good. Lateral epicondylalgia. Good. Good. Let's see. Maybe some, what are the kinds of things that may be wrinkled in there? What kinds of muscles may be involved in that lateral elbow pain? I won't belabor the point.
Extensors.
Yeah, good. So some extensors, some wrist extensors, good. What other muscle kind of wraps right around the radius? Supinator, yep, good. So maybe some supinator issues. Good. Okay, so for this technique, I like to do, also AKA known as Mills manipulation. It's kind of a fun one to do. Is there anyone who learns well by having it done on them that I can demonstrate on? I can't do it on myself. Yeah? Yeah, come on up. So we're going to do this one. We're going to do a carpal technique. We're going to do proximal fibular. And we're going to do talocrural with some subtalar differentiation. So thinking about if there's one that you want to have done on you might be interesting. Sorry. Yeah. Right there's good. Do you care which side? Right side's good?
Yeah, that's one.
Any issues I should know about there?
Nope.
Okay. All right. Good deal. So I'm going to have you turn and face this way. Sorry, guys. We get the camera out. We get the people. We're good to go. All right. My hands are freezing. I apologize. So again, finding that radial head, right? And if you're not sure, you can rotate their forearm so that you can find the back of that radial head. And what I would say, your thumb is going to be providing that force. So you want your thumb to be nice and firm and stiff, but you want to also be careful about not being too pinpointy right on the rim of the radius, because it doesn't always feel that great. So try to find a spot where I like my thumb to be right, like the radial head is like right there on the top of my thumb, and my thumb is on kind of that has a neck of the radius. So I've got the head and the thumb. My thumb on the neck. So our patient position, patient's going to be heading into full elbow extension and full elbow flexion. How you doing? Is that okay for you? Okay. So I'm doing a super slow variation of the technique. My right hand is going to maintain her wrist in full flexion. My left thumb is going to be driving it's called a posterior-anterior force. If we put her more in anatomical position, it's pretty much posterior-anterior. There may be a little bit of a lateral component to it because we have her twisted around. Okay. Is it tender there? Okay, good. You guys are so young and healthy. It's fabulous. All right. So what I would say is before you thrust, make sure you feel like you can find the barrier. So you've got some, what is your name?
Tori.
Tori's got some good motion here. So it may be just a little tricky to find that end range. But when I get ready to go, I'm going to say, does that feel okay there?
Mm-hmm.
Is it okay if I give you a quick thrust?
Yeah.
Is it okay if I do it one more time?
Yeah.
And applying that pressure with my thumb, flip, the wrist stays steady, and then it's that last little bit of extension. How many rounds of manipulation do we do?
As many as it takes, but not too many.
50. Okay. How do we know it's as many as it takes? There's a couple answers to that.
You're not getting any benefit.
Definitely. Oh, good. Definitely test, treat, retest. That is like the solid bottom line. You also want to do some self-assessment, right? Did I get them to the range that I wanted? Did I take up all the barriers? Did I feel like I got a good quick thrust at the end of that barrier? Was it fast enough? And if you're thinking all of those things in your head and it was perfect and you didn't get a cavitation, if it was perfect and you didn't get a cavitation, do you need to do it again? So the research says no, but then the research also, if they don't get a cavitation, they frequently do it 3 times, whether they were happy with it or not. So typically, assess your patient, right? Their irritability level. If they're highly irritable, you probably don't need to be doing this 3 times. Once is probably good. So it better be a good one the first time. But if you're happy, then step back and move on. So the elbow techniques, the knee technique we're going to show today, the knee for sure is a little bit trickier with the cavitation. Elbows, you guys probably get some cavitations. The wrist is a lot easier to get some of that, and maybe we'll get some of that with the ankle too. So assess your technique. Try it a few times. Talk to your partner. Everybody's got 2 arms, so don't over-technique it on your partner. Questions?
Why is she keeping the wrist in flexion? Why is that maybe an important component to maintain through the technique?
It keeps tension on the wrist extensors.
Which is important. Why?
I'm not sure. I was hoping you would just accept that answer.
You're on the right path of thinking. So
Yeah.
it does that. So what might that do throughout the course of the delivery of the technique to maybe facilitate patient safety? Keeping tension on wrist extensors, that's passive insufficient.
C.
Okay. And so some of the wrist extensors in question do what? And if we're keeping them on tension and they cross the elbow, I'm thrusting quickly into elbow extension.
Prevent hyperextension.
No hyperextension.
So a
Teamwork.
non-negotiable piece of the Mills technique is to make sure that you maintain wrist flexion throughout the delivery. Cool. All right.
Try it.
All right. Cool.
Yep.
I'm going to pause this.
Yeah, sure.
Good. So the next technique we're going to go over is the scaphoid manipulation. And I was just saying that there are some folks who have scapholunate instability or some carpal instability. So if you feel like you're one of those folks, if you're not sure, let me know. We'll check it out. But if you experience troubles with clunking sensations, things like that, maybe not the right technique for you. Okay. Do you care which wrist?
Nope.
Okay. Let's go with the right wrist. So number 1, find the scaphoid. So scaphoid. How did you guys learn how to find it? Any nice tricks? It sits at the base of our anatomical landmark, kind of. It's a multiple anatomical landmark that sits right there. It's at the base of our snuff box. Yay, good, excellent. Okay. Now that being said, it's at the base of the snuff box, but that's like one angulation of it. We're not really going to grip it laterally. We're going to be gripping it posteriorly and anteriorly. Thumb and index finger, typically, I like to overlap. Both thumbs on top, both indexes on the bottom, and then just make sure you find scaphoid. So hers sticks out very nicely. And I shouldn't call you her. What's your name?
Cameron.
Cameron sticks out really nice. The next bone over, kind of in that divot, is going to be your lunate. So if you're in the divot, you've gone too far over. So finding the scaphoid. In the picture, they have the patient lying down. So you'll see this technique where the patient supine, standing works well. Our end position to get us to that barrier, to take up the slack, is our patient's in standing. We're going to be at the end of elbow extension and wrist extension. And it's going to be a little thrust at the end of that. So almost, some people might call it like scaphoid whip, that sort of thing. Okay. How's that feeling so far? Good. Good. You've had a bunch of mobilizations already. So it should be ready to go. Nice and warmed up. So we're going to maintain that contact with scaphoid. We're going to take her to that end position so we know where we're going. Does that feel okay?
Mhm.
Is it okay if I give you a quick stretch right there? Sure. And this one I always need to do a couple. Last one. There we go. Okay, questions on that one? Gonna give it a try? Excellent. Oh, thank you.
Yep.
What do you think? What does the proximal tib-fib joint do?
It's rotational.
Good. Yeah. Yeah. What's it? What do we need it for? Why is it important? Can we just like get rid of our fibula?
Yeah.
Some patients do if they need a bone graft. Fibula is a choice of some doctors to choose for bone tissue, but we prefer to hang on to it. It's there for a reason. What does it help us with? What's the other end of the fibula?
The ankle.
Good. Excellent. So what does that tib-fib joint do at the other end?
Be very stable.
Yes, good. Excellent. Excellent. So the tib-fib joints are to help us provide more stability for the lower extremity. If we think about some of the biomechanics that may occur at the tib-fib joint, if we're distally, so down here at the fibular head, if we're moving into dorsiflexion, how does that fibular head glide? Anterior or posterior?
Posterior.
Good, excellent. And if we're going to plantar flexion, it glides anterior. What happens at the proximal fibular head? The opposite. Good. All right. So when might we want to improve those motions? What kind of injuries or patient presentations?
Ankle sprain.
Good, excellent. Good. So lateral ankle sprains, lateral ankle pain, some chronic, maybe even some tendinosis types of things, some, do you guys even say peroneals anymore? What do you guys, peroneals or fibularis?
We got both.
Oh my goodness, okay. Maybe some muscle dysfunction, some stability issues. If we go back to all the reasons we do manipulation, right, we're not repositioning the joint, we're providing input into the joint to help us with maybe improving our range of motion, maybe improving our muscle function. There's actually some really cool studies that looked at some different manipulation techniques for the foot's post-acute ankle sprain. So some really cool stuff. Okay, can I borrow someone's knee? Cool. All right. Give me possibly the biggest knee in the place.
The man with pants
I
on.
do want to do the ankle though.
Yeah.
Because mine
Ready?
has ankle.
Got it. We're going to get you on your back. Face up. Yep. And you cry.
Go over here.
Yeah, that's probably going to be best. All right. Now, we talked a lot about ankle.
There we go.
This is perfect. But a patient who has maybe lateral knee pain, even if it's not a tibiofemoral joint issue, it may be worthwhile to check out that proximal tib-fib joint as well, because it can certainly contribute to lateral knee pain. Okay, so our patient is in supine. And first off, locate your proximal fibular head. And if you're not sure, you can certainly do some tibial rotation. Feel that pop out at you, so right there. We are going to be using our hand behind the fibular head, trying to sink in the first metacarpal phalangeal joint right to the back of the fibula. We're going to use our other hand, provide some tibial external rotation to help us be able to take up the slack more. We're going to take up all of our forces and then thrust from there. Now, a couple of things. There's a lot of soft tissue here, a lot of calf muscle, so we want to try to scoot that out of the way. So as I sink in, I'm going to bring that calf material laterally so my MCP can sink in right behind the fibular head. That's my goal. And you may have to some extent, if you've got a lot of muscle tissue, You may have to kind of trust that you're there because there's a lot of soft tissue between you and the fibular head. But that's why we'll do external rotation, we'll take up flexion, and we'll get that compression so we can really start to feel it pressure into our MCP before we thrust. Okay, so we're here. Now we're going to provide some external rotation of the tibia. So I'm grasping distally, so I have a better grip down here, where I can rotate the tibia externally. So his heel is going to end up going towards his midline during flexion. So I'm sinking in. I'm externally rotating the tibia. Femur is almost vertical, usually, to get better technique. External rotation, taking up that last little bit of flexion. Make sure we stabilize. Are you okay right there? Okay if I give you a quick stretch? Don't like it. Coming back in, rotating. One last. Quick stretch. Okay, so we'll try that. Find that fibular head first. Try the skin lock behind by pressing the calf out of the way, sinking the MCP in, that external rotation, that flexion, and then that last little thrust at the end.
Are you forward at all with that MCP on that fibular head, or are you just pressing down into extension?
So the thrust is only through flexion.
Okay.
You've already taken up all the other forces.
Okay. Gotcha.
But you do want to make sure you're stabilized. So you don't want anything moving.
Yeah.
So there is always that counterbalance. But the thrust is pretty much just through the thrusting hand. Okay, we've got one more technique. We're going to go over the talocrural distraction manipulation. So for your talocrural joint, I'm going to try to show you some variations of how you might maybe try to focus it a little bit more towards talocrural versus subtalar by using some joint mechanics in there. But really the technique does not isolate talocrural. It really is talocrural and subtalar as well. So we're thinking about this. What indications might we think of? What kind of patient presentations for talocrural? Definitely, good. Ankle pain, good. Talocrural joint, since we're on biomechanics anyway, what is the majority of the motion that occurs at a talocrural joint?
Or sliding. Roll.
Good. Which directions? Which motions do you most associate with talocrural?
Dorsiflexion.
Good.
Plantarflexion.
Good. Excellent. Nice. So maybe someone who has some limitations specifically into dorsiflexion, plantar flexion. Good. If we think about subtalar, so talocalcaneal joint, what kind of motions might we think of more at that joint? Good. Excellent. Nice. So we're going to use kind of those concepts to help us maybe localize the technique for one or the other. Good. Okay. Anybody that would like this practice? Oh, good. Excellent.
Limited motion on the left side.
Oh, do we need to do a test, treat, retest?
Ooh, yeah.
Yes.
Is there anything in particular that you're really noticing with?
No, just when I'm like looking at the motion.
Okay. What about like a deep squat? Would you feel it then?
Yeah, it doesn't hurt, but I
Right,
noticed
but
that
you would feel the difference?
Yes, definitely.
Can we do shoes off?
Yeah, socks off?
Yeah,
Socks
probably.
fine.
Is that okay?
Yeah, they're a little thicker.
We'll definitely need it for the technique.
Sorry if they're smashed.
I have dealt with smelly feet for 16 years. I'm a specialist. in smelly
Oh
feet.
yeah,
Oh, yeah, weird toes?
That one.
Oh, that's
the coolest show ever.
That is so cool.
Okay.
All right. So show us what your deep squat looks like.
It's like when I lean over one versus the other.
Yeah.
I can tell I have a lot more motion over here.
Gotcha. Okay.
Yeah, I
We totally lost you on the
Right.
camera.
Yeah, move that chair.
You're going to have to take your word for it. Is this any different? Gotcha. So do you feel like your main limitation is dorsiflexion, or do you feel limited in plantar flexion as well?
Well, I've never looked at plantar, but mostly in dorsiflexion.
Okay, cool. Well, let's go ahead and get you up on the table on your back, so face up, and we can at least take a look at your active plantar flexion.
Okay.
So from supine, I'm going to have you point both feet straight ahead. Mm-hmm. You You got it? We'll just look and see.
Good go. It's like 180 degrees.
They may be criticizing your ability to point. They look pretty good.
Compliment.
Yeah, it's hard to, it would be hard to see. Okay. All right, so for our technique, so if we're thinking about talocrural, dorsiflexion, plantar flexion majority occur at talocrural. If I want to limit subtalar mobility, how might I take up the slack in subtalar to target more talocrural?
Speaking to like end range dorsi.
So if I put them in end range dorsiflexion, I'm probably reducing the mobility at talocrural. Does that make sense? Okay, cool. So if I want to target talocrural and I want to maybe limit a little subtalar, the suggestion is a little bit of supination. Now, I still have to be able to keep my hands on her foot, so we're kind of in neutral. We're not in that real deep dorsiflexion that you might see. Now, that is not incorrect. You'll see this technique done in deep, deep dorsiflexion. In this traction, that's fine. We're just maybe playing a little bit with some biomechanics. Not that that even makes a difference. So some supination, putting her in that neutral position. Table's a little low for me, but that's okay. I'm going to take up the slack. How does that feel? Is that okay? We've got all sorts of stuff going on in there. All sorts of stuff. What is... How is your ankle?
I have a positive and anterior drawer on both ankles.
Of course you do. So a good question is always, am I stressing her, like her talofibular ligaments?
You're waiting for an answer, aren't you?
I'm just going to let it hang out there in space. So, a little bit of supination. You okay there?
Yeah.
So I'm going to lean back and just that quick. I'm not going to do that more than once. There's a lot of movement in there for her, which is fine. If I want to target more subtalar, maybe I'll put her purposefully into more dorsiflexion, taking up some of the slack out of talocrural. And it's similar right now. Just got a lot less motion there. Questions on that? Okay, all right. See what you can do. Again, quick sharp. This can be a little tricky to find that sharp, so it's a good one to practice.
Okay, check your spot.
You got some camera check.
Do I got her even in there? Nope.